Hello guys. So today we'll be discussing about an interesting topic, HME, right? So you must have seen this device must be using in ventilated patients, right? So also this device is called artificial nose, right? So let us go step by step. So basically it is a device which takes up the normal humidification function of human airway. So let us understand regarding the humidification process of normal human airway, right? So what happens during inspiration? The inspired air achieves a temperature of around 37 degrees Celsius and 100% of saturated vapor pressure, which is equals to 47 mg per liter of water, right? So a temperature of 37 degrees Celsius and 100% of saturated vapor pressure is achieved at a level, some some people say it's just below the carina or mid-tracheal level. So in this region, this condition is achieved at temperature of 37 degrees Celsius and 100% of saturated vapor pressure, which equals to 47 mg per liter of water. Also, this unit is sometimes varies. It is either mg per liter or gram per cubic meter, right? And this point is also called isothermic boundary. So the point at which these two conditions appear, it is called isothermic boundary. So basically when a patient is intubated or tracheostomized, we are bypassing the normal upper airway, right? So some functions of the upper airway like humidification, some filtering function and some warming function, they needs to be taken care of artificially, right? So generally we do have two modes of humidification. One is active and second is passive. Active humidification devices are generally electronically heated and attached to the inspiratory limb of the breathing circuit, right? But the passive ones, one example is HME, and today's discussion will be restricted towards HME or the device used for passive humidification, right? So why do we need a particular level of humidification? So as we had discussed previously, at the isothermic boundary we get a absolute humidity of around 47 gram per cubic meter, right? So minimum of 33 gram per cubic meter is needed in order to maintain the mucosal integrity, right? So 33 is needed. So as per the AARC recommendations, that means American Association of Respiratory Care, so what does the society state? It states when we are using active humidification devices, we should target a range of around 33 to 44 mg of water per liter, and when we are using a passive device or a HME, our target should be around 30. This is the ideal recommendation. This value stands for absolute humidity, right? So with this much of level, our mucosal integrity will be maintained as per various studies. So we must target a minimum level of 30 to 33, right? Okay. So when we use a HME, is it efficient enough to maintain this much of level of absolute humidity? No. Generally, HME provides a range of around 20 gram per cubic meter of absolute humidity. Some literature say its value extends till 30, but it is practically difficult to achieve this much level of humidity, right? So this is not adequate for long term ventilation, right? So basically it is a humidifier and moisture exchanger. A stand for humidifier, M for moisture, and exchanger, right? So it basically replaces the three functions of upper airway: humidification, warming, and some filtration. Not fully, but some part of filtration. So this is a standard HME, though there are hundreds of models available, right? Let us understand its various parts. So these are standard connectors, right? This is connected to the Y piece of the circuit or ventilatory end, and this is connected to the, let us say, to the ET tube or patient end, right? And these are standard connectors: 15 mm, 22 mm standard connectors, right? So what is this? This is a standard lever lock CO2 sampling port. So the CO2 sampling line gets attached over here, and it runs to the monitor to provide you the capnogram, right? And this is the corrugated piece of paper with hygroscopic material attached over it, right? And it is covered by transparent plastic. So why transparent? Because it is easier to visualize whether it is clogged with secretion or blood, right? You can inspect the condition. So this is the corrugated cardboard with hygroscopic material. So hygroscopic material is attached towards the patient side or the ET tube side. So in this side, hygroscopic material will be there. Sometimes in some devices there is a additional filter over here towards the ventilator side. Okay, in some devices you need to check it whether this additional bacterial or viral filter is there or not. It is not there in each and every devices, right? So this is the basic structure of a HME, right? And remember, it is one sided and it cannot be arranged in a wrong way or the opposite way. So as we discussed, this is the patient end or ET tube end or tracheostomy tube end, and this is the ventilatory end. Okay, so this polarity cannot be reversed because these hygroscopic materials are present in this side, only in the patient side. These are not present in opposite side, right? So it cannot be reversed. So what happens? Let us understand. This is a basic Y connector, and here is our HME, and this is our patient end. It is a very bad diagram, so you can consider it an ETT, and this is patient end, and this is ventilator end. This is Y piece connector, right? So what happens here? So in this HME, the hygroscopic material are there in the patient side of the HME or patient side of the device, and as we had already discussed, there is an additional physical barrier or filter which is made up of plastic. Filter or physical barrier, and this is the hygroscopic material, right? Clear? So what happens? This is patient end, this is ventilator end, this is Y connector, and this is ETT or tracheostomy tube, right? So what happens during expiration? The filter collects the expired air, right? Though from the patient end we get the expired air. Okay, air gets passed through the HME, but the water vapor remains over the hygroscopic material of this side or patient side of the HME. So these just remain on this side of the HME, right? So what happens during inspiration? When the inspired gas enters through the HME towards the patient, it carries the vapor and the heat with the vapor left during the phase of expiration along with that towards the patient, right? So this is the simplistic way of defining its function, right? So as we had discussed, in some model there is a physical barrier. Let me draw another diagram for you. This is expiration and this is inspiration, right? This is patient end and this is ventilator, and here is the Y connector. So what happens during expiration? The water vapor and the moisture gets deposited over here in this side, right? And during the expiratory phase, these are just collected and move back towards the patient. And what is the action of the physical barrier? Sometimes it acts as a bacterial filter. If there are some bacteria, they just get filtered by this barrier. That's it. But remember, it is not present in all the models, right? So in expired gases, we have a saturated vapor pressure of around 47 mg per liter of water, right? And this vapor pressure is maintained by using this device. So if there is not adequate humidification, what are the consequences? So theoretically, what happens? Mucosa gets thickened, right? So after the mucosa gets thickened, the mucociliary transport is hampered. So you are aware of the importance of mucociliary transport and its action on secretion clearance, right? Then gradually mucosal damage occurs, followed by desquamation occurs. Also, secretion become thick and can lead to atelectasis, right? So these are the consequences of inadequate humidification, for which we target a particular level of humidification, right? So what are the factors those affect the efficacy of HME? So when the HME is used for a prolonged duration, let us consider for more than 3 days or 5 days or 8 days, and the patient is having higher amount of secretion or bloody secretion like that, so it gets clogged and resistance to flow increases. Also, the efficiency is decreased. So as the duration increases, we need to inspect the HME, the transparent site, whether there is mucus or blood clogging is there, and we need to change it periodically. Some guidelines say ideally it should be changed in every 24 hours, right? But some clinicians have used HME for a prolonged duration of up to 7 days without any difficulty or without any significant rise in complication rate, right? So it is recommended ideally to use HME up to 2 to 3 days, and it needs to be individualized, right? So if you see, there are more than 4 HME changes per day due to heavy amount of secretion or thick secretion or blood. This is a absolute contraindication for using passive humidification. You must switch to active humidification device, right? So what are the other factors when you are using a high tidal volume? So what happens? Let us consider a tidal volume of around 700 or more than 600 you are using. So by the end of the inspiration or by the middle of inspiration, let us consider you are giving a 600 or 700 ml of tidal volume. So when the 400 or 500 ml is gone and rest 200 ml is remaining, so what happens? The HME is completely dehydrated. So its efficiency is decreased, right? So when you are using high tidal volume ventilation, you should take care of this point, right? So what is the indication? Any patient in which the upper airway is bypassed, whether it is intubated or tracheostomized, we should use any mode of humidification, whether it is active or passive. So passive humidification process devices are best when it is used for a shorter period of time, like intraoperatively during OT or for a short ICU stay. If ICU stay is expected to be more than 4 to 5 days, we should switch towards active mode of humidification, right? So now let us discuss what are the contraindications for using this device. So any condition which requires a tight control of tidal volume, like in ARDS with low volume ventilation, low tidal volume ventilation. Let us consider a patient of 40-50 kg in which we are using a tidal volume of 5 to 7 ml per kg body weight, in which each and every ml is important for us. But when we are using a HME which has a device dead space of around 50 to 100 ml, so sometimes you are asked in the Viva, like what is the dead space of this device? Depending upon the manufacturer, it varies from 50 to 100 ml. Generally, it is around 50 ml, but some devices in which the dead space goes till 100 ml, right? So, conditions in which tight control of tidal volume is needed, or in low tidal volume ventilations, the dead space factor needs to be taken care of, right? So, secondly, when there is large amount of secretion or frothing, we need to avoid it. Third, when the minute ventilation is around more than 10 liter per minute, its efficacy decreases and the humidification process is not adequate. We need to switch to active mode of humidification, right? Fourth point, when there is a large air leak, for example, bronchopleural fistula, in that case also the efficacy decreases, right? Fifth point, when we expect a long term mechanical ventilation, patient with severe ARDS, right, we need to have a long term mechanical ventilation. So in such scenario, active humidification is better. Sixth point, if our patient needs a very frequent nebulization, so with patients with very frequent nebulizations, like patients with severe hyperkalemia or due to some other indications, if we need to nebulize the patient more frequently, we need to disconnect the circuit again and again and remove the HME from the circuit and nebulize the patient. Then we will connect it and nebulize the patient. So in order to avoid frequent disconnection, we can switch to active mode of humidification, right? So what happens during nebulization? So what some people do, they just place the nebulization machine, the nebulization device in the downstream, right? So here is the HME, here is the Y piece or ventilator end, and this is the patient end. and this is the ET tube. They just connect the nebulization device like this, and they assume the HME is in the back end and patient will be nebulized comfortably, right? So what happens here? The inspiration process is okay, the nebulization occurs like this towards the patient end, and what happens during expiration? During expiration, these nebulized materials, they pass towards the HME and they just deposit over the hygroscopic material of the HME, and it gets clogged and its efficacy decreases. So during nebulization, we should remove the HME completely of the circuit, right? So these are the basic aspects of HME. So we'll discuss regarding active humidification and those devices in some other video, right? So read more about it and let me know if I can help you by any means, right? Thank you.